With that, I want to turn to our next speaker, our next welcome. And this will be coming from Washington, D.C. With the assistance in planning this event, we have the U.S. Department of Health and Human Services. And I'd like to give a warm welcome, everyone, to Latecia Engram, coming from HHS on behalf of our partner in organizing this, the Chief Data Officer of U.S. Department of Health and Human Services, Mona Siddiqui. Everyone, welcome Latecia.
Good morning. Thank you for having me here in sunny California, emphasis on sunny. My name is Latecia Engram, and I am a public health analyst in the Department of Health and Human Services with the Office on Trafficking in Persons. And I'm here today to talk about creating value from data at HHS. Before we get started, I just wanted to kind of put out a couple of things to help you understand the context from where I'm speaking from today. So most of you are familiar with multiple areas of HHS, and you may not know it. The Department of Health and Human Services is comprised of several agencies like NIH. You may have also heard of the Centers for Disease Control and Prevention, the Health Resources and Services Administration, which serves the community health centers, as well as the Administration for Children and Families. And this, along with staffing and operating divisions like the Office of Minority Health or the Office of Women's Health, comprise the Department of Health and Human Services. As I talk to you today, I'd like to emphasize a couple of qualities of the data analyst and talk to you from that perspective. And I'll give you a little bit of a snippet of what may be those qualities that you might see in a data analyst. One of those qualities is that they are fiercely passionate about the programs that they work for. They are generally persons who spend late hours making certain that the data is accurate and that we are able to provide timely responses to our secretary or communities and grantees that we are serving. The second quality is that we are, as stewards of the federal government, we see a priority in being able to support patients, the persons that we serve, and to protect the data. That comes through a number of laws and regulations that may be sometimes in conflict with what we are able to produce and provide to the larger community. But regardless of those sometimes polarizing characteristics, we all have a vision. And this is a vision that actually came out of the Reimagine Data Initiative, or the Data Sharing Project. And as you can see, our vision is an HHS where data are shared, connected, and analyzed in a responsible way. But sometimes for this project, it's really about operationalizing what that means in the department. How does this happen? What are the barriers and challenges in the way? And how are we able to develop a comprehensive plan in order to address those issues? So another key underlying foundation for the Department of Health and Human Services is that we realize that data is a valued strategic asset. And by that I mean, for example, whether it's an outbreak and detection and response that came out of the Centers for Disease Control, or perhaps a biomedical research from the NIH, or even program evaluation from the Administration for Children and Families, data is the undercurrent that informs public health interventions and actually helps us understand program decisions in a way that impact lives. So without the right data, or even without quality data, we're at a stopgap and unable to do the work that requires us to move forward to innovate. So a wonderful event happened, actually under the leadership of Dr. Mona Siddiqui, the Chief Data Officer for the U.S. Department of Health and Human Services, also being supported by the Chief Technology Officer. We held a series of events back in December of 2017. This Opioid Symposium and Codathon had a unique theme, and it was the first of its kind in the Department of Health and Human Services. Our theme was connecting data to save lives. And the opioid crisis, as you know, is very important because the HHS has a unique role in educating persons and communities through the programs that it already serves. We serve the rural. We serve sparsely populated populations. We also service persons who are medically underserved, the vulnerable, and at risk. But by also using those as in-ways or entrees to those communities that are best served, we have a very unique role in actually spearheading and moving forward the agenda of addressing the opioid crisis. So led by Stanford Medical X, HHS held a design-a-thon to engage stakeholders in brainstorming design solutions. So outputs from the design-a-thon actually informed the judging criteria for a codathon. The second set in this series of events was an HHS symposium, and it brought together leaders in the front lines of the opioid epidemic for TED-style-like presentations, and also panel discussions showing the promising practices in the opioid crisis. And finally, a codathon. A codathon itself was attended by 49 coding teams that were competing in person over a 24-hour period. Now, those as this codathon were represented by persons from technology, nonprofits, some industry startups, as well as academicians. And the winning teams from each of the challenges, or each of the tracks, which were prevention, treatment, and usage, those winners went on to win $10,000. But the huge win for the department was larger than this, because what we benefited from was a multitude of technology solutions that actually impacted not only patients, but providers, state health departments, as well as departments of health. Now, the larger win is that we have some lessons learned that came from this codathon. The codathon actually was a vehicle for us to rapidly realize and provide and get evidence on the challenges in accessing data and ensuring quality data. This event actually catapulted HHS into a learning mode. And so our focus began to turn to how do we address these challenges? Are we right about what we found? These challenges came up because of the codathon, but are these actual real challenges for HHS? And so the work began over a summer of a very intense semi-structured interviews with the senior agency officials identifying data sets of value, of most value to the department in this area. We conducted that work over a time of a very intense time frame, about the summertime, collecting data, collecting information about the metadata that's being structured, how the data was being stored, what are some of the technical aspects, but also really pointing to and understanding some of the cultural norms that undergird how data is shared in the department. And just last month, the department released 2 key reports. The first was the current state report of HHS data sharing, and it identified 5 key issues. One was the process for data access. We found that there was a lack of consistency and standardization and even transparency in how data requests are being handled. The second was the technology, that there's variation amongst the various formats. If it's a survey from NIH, it may not match up with the Centers for Disease Control. Some of the way the information was even stored provided challenges in being able to provide that to the codathons participants. Another key aspect is the regulatory environment. When the use of data use agreements is a problem not only for the states, but also within the Department of Health and Human Services. The disclosure risk management, something that's on every data analyst's mind. How do we protect the personal data that the patients are willingly providing us and ensuring their privacy? And finally, the real big one was the norms and resource constraints. Not only are data analysts very protective of the data that's actually being collected, but there's also a fear that sometimes the misinterpretation of that data by giving it to a second party could come back to reflect poorly upon the program. There's also strained resources. That data analyst that sometimes spends an inordinate amount of time analyzing data, making certain it's clean, can be sometimes overwhelming to that person, and if there's not enough persons that are actually understand, it creates a burnout. The third effort here is a future state report that we're currently in the process of developing. And from the current state report, it goes a step further in identifying some of the key practices that already exist in the department that had not been known by our other partners or other agencies, and our inability to share the data. So by taking these issues and challenges and turning them into recommendations moving forward, we're up to developing a comprehensive plan that will be reflected in a future state report. So where we are now, and I hope this is kind of clear and hopefully depicts where we are. If you can see this image behind me, there is a silo. And within every silo, there's a program. Within every program, there's a data set. And they're pretty much organized within the agency, in some cases not. But ultimately, for us to come up with a comprehensive perspective, we've got to get to one jar where all of the organized data sets are organized and being able to access them in a timely manner. And we know that there are some key steps that have to happen as we develop this plan in order to get there. One of those is reducing the redundancies in the type of analytic tools that we have. We pay multiple vendors for the same licenses over and over again across the agencies, not as cost efficient as it could be. Eliminating numerous interagency data sharing agreements. Reducing costs associated with multi-purchase analytic tools, maximizing informed decisions and policymaking, and ultimately demonstrating measurable gains from this collaboration and a return on investment. So all of this we hope can be addressed by having a comprehensive plan that will take into consideration all the challenges that have been identified and move the needle forward for us as an agency. But in the end, what we all want is for HHS to be able to access quality data that can provide a holistic view of the problems and evidence-based solutions. What does success look like for us? Here are a couple of components. Most of them are very small pieces of three basic areas: people, process, and technology. And these are what they resonate for us as tangibles that we know must occur. But the larger piece of this is something that we're going to actually tackle that's actually is more important as these tangibles. And one of them is engaging the end community. The federal government and our peers, those data analysts, are our end community. And have they had a voice in being able to determine it and help guide some of to articulate the data sharing challenges as well as some of the solutions that could be part of that. This second part is a focus on value and quality to the department, as well as constraint mitigation. Something that we sometimes will get stopped like anyone else, but how can we actually put in strategies to address those constraints? And empowering individuals in interactions, even as we develop processes and tools. Sometimes the individual is part of that, is not part of that, and we want to be able to move that forward. And also customer collaboration. The agency is a customer, and we need to work together more, and that's what we're up to. So success for HHS is being responsible and collaborating on insights that really matter and make a difference. I want to thank you for your time this morning and listening, and I'm going to enjoy sunny California.